Hello, I'm Dr. Paul Chidester, the Chief Medical Officer for Monarch Medical Technologies, where we make EndoTool insulin dosing software. Today, I'm joined by Dr. Anthony Pick, who's an Assistant Professor of Endocrinology at Northwestern University. And we'll be discussing a recent guidebook that Monarch has produced, which summarizes the most recent 2024 Society for Critical Care Medicine guidelines for glycemic control. So, Dr. Pick, if you could just enlighten us with a brief overview of this guidebook that we've published.
The Society of Critical Medicine have come up with new guidelines. And I think it goes to this issue of we know that hypoglycemia and hypoglycemia both drive harm in critical care patients. So you have this nice piece that I've reviewed. And what I liked about it, because I'm expert, read the stuff, think about it, it's a nice summary. And it kind of highlights the importance and some of the nuances in that field.
And what would you say are some of the highlights that have been listed in those guidelines and that we've highlighted in our book?
It clearly delivers, number one, the threshold to intervene is 2 glucose above 180, which is a fairly common situation in critical illness. That's number one. It highlights the importance of controlling hyperglycemia while avoiding hypoglycemia. The third thing that it highlights, which obviously we're having a discussion with EndoTool, is that there's a drive from the professional societies and the expert review is the value of computer-assisted algorithms, differentiating EndoTool, for example, from paper protocols. So being able to do it in an effective and safe way in terms of a low risk of hypoglycemia. And then the fourth takeaway would be the operational issue about the burden on nursing staff and the burden on patients for the glucose monitoring, and making the point that the EndoTool is actually dynamic in that area. So I think that struck me as another consideration as well.
There was a lot of discussion in that article about what's the appropriate glycemic goal. And they certainly ended up tending toward recommending a higher glycemic goal. Yet when you looked at the real detailed analysis, there were a number of studies that really actually favored a lower glycemic goal. Can you comment on where we should go with that?
Yeah. Actually, I think two things. I think if you're talking about dynamic goals where the field might be heading, that's another advantage of EndoTool in terms of actually being able to target. I think the paper protocols are not that nimble. And I think what you're alluding to is Dr. Kinsley's work, where the risk might be different based on the preceding A1C, even whether you have diabetes or not. And then to your point, you've got this complicated database of low glucose targets versus high, and then that debate all the way back to the study from Greet van der Berg, in terms of how they did it and how much was that related to hypoglycemia. So that if you dive into the details of the protocol, how you get there is probably important as well. So I think that's where you also, in the absence of high level studies, meaning powered large scale randomized controlled trials, you take the evidence and apply it as best you can. And I think some of that nuance is what we're discussing now is lower better, but what about hyperglycemia? What about individualizing targets based on preceding A1C or based on whether you have diabetes or not in the first place?
Yeah, they seem to have a real fear of hypoglycemia in their summary. And I think the nice part about EndoTool is you can really avoid hypoglycemia with the product. And do you see any other major hurdles to implementing these guidelines in a hospital?
Yeah, it's a good question because my interest is process improvement and sort of the challenge we have to do systems change. So I think I think it goes to, and I think it's kind of highlighted nicely in your piece, is that it does help the nursing burden and this issue of being able to manage things in a population. So I think it highlights again the value of the software automation and the value of EndoTool versus the paper protocol. And the reason why that's important because they're different hospitals at different levels of sophistication, and even within academic centers, we won't mention any names, but I know academic centers that are still paper-based, and they have this firm belief that they can do it safely, but they may not doing it with even the metrics to say that they can. It's one thing to say we can, it's another to track your hypoglycemia rate, for example. So I think those are all practical issues.
Excellent.
Yeah.
So as we've discussed, there's a lot of valuable information in this ebook. And what would be your recommendation to readers to consider looking at this?
When I read the ebook, I thought it was a really nice, well done summary, easy to follow, and sort of. I always looking for things that add decision support. Is that I thought it was actually helpful, not just for endocrinologists, who read this stuff every day, but for the critical care folks doing it, the critical nurses, the critical pharmacists. So I thought it was a piece that was very accessible and very fair and balanced.
Well, I thank you very much for your time today, and I hope that our audience will take a moment to read our summary of those guidelines because I think they're very informative and really will help drive clinical care to the next level. So, Dr. Pick, I thank you for your time today. Appreciate
Okay,
it.
all right. You're very welcome. Take care, guys.